Okay, recording. Okay. Okay, so grades are posted last night, so you got my email. Either I'm happy to meet with everybody. I really would like to meet with the students that got below a 78 to review the exam and talk about how you prepared. I'm just curious from this group, and just give me a yes or no, if you attended a live session. Even if you listen to a recording, I'm talking live session now. Bethany, did you attend a live session?
I listened to the recordings.
Okay. Kylie, what'd you do?
I didn't go to a live session, but I listened to the recordings.
Okay. Sarita, what'd you do?
Listen to the recording.
Okay. Lashana,
Live session,
you went to a live session. Which one?
Dr. Lundy.
Okay. And Jamie.
I listened to a recording.
Okay. And Andy.
Recording.
Okay. Okay. All right. Shaylee. Hey, Shaylee. Good morning. Shaylee, quick question. Did you attend a live review session or did you listen to recording for the exam?
I attended a live review.
And who
I
did you?
listened to a recording.
Okay. Which one did you go to?
I don't remember what her name was. It
Okay.
was the one on Friday at like 6.
Oh, probably Diane. Okay. Rosie's coming in. Hey, Rosie.
Hi.
Hey, good morning. Quick question. I'm just trying to do an inventory here. For exam 1, did you attend a live session or watch recordings?
I attended yours.
Oh, that's right. Okay. All right. All right. That's right. Okay. All right. So, okay, let's just keep letting people in. I really want to start on time here. One, two. Hey, Diane.
Hi.
How are you? Good morning. Hey, quick question. Just doing a survey here for exam 1 review. Did you attend a live session or do recordings?
I attended the live session.
Whose?
Yours.
Yeah, I can't find I didn't have that. Okay. I didn't have you on my list as my session. Okay. All right, great. All right, so I think 2, 4, 6, 8, 10, we're missing one person. So we are recording. Welcome to week 4. I'm going to do a lecture today, a review of weeks 3, last week and this week. There'll be 5 chapters, 22, 23, 24, 29, and 30. There's our last person, Melanie. Okay. Get Melanie in here. Hey, Melanie. Good morning.
Good morning.
Hey, good morning. Hey, quick question. On your exam review, did you live session or recordings?
Recording.
Okay, thank you. Okay, so couple things. One is I posted grades last night. It was a mixture all the way around in all 3 of my classes. Some people did really well and some people didn't do really well. And so we talked about this in week 1 of not putting yourself behind the 8 ball after exam 1. But here we are. So what I need you guys to do, you got my emails last night. One of the most important things I think to do if you're below a 78 is get in touch with me. And I have a lot of emails from last night and this morning. I've responded to a couple of people. As far as scheduling, I am in, so now we start, they're called at-risk meetings. We do this with every campus. So I have, I think, 9 campuses. So if I have students that are considered at risk, which if you're below a 78, you're now considered at risk, I have to do a report on you that involves your exam grade and then all your homework and everything up to week 3. Has anything been late? Is anything missing? And then I have to present you at an at-risk meeting, and that at-risk meeting has your dean, has your administrative staff at the campus. So we do this weekly. They're on Tuesdays, Wednesdays, and Thursdays. So like today, I have 3 one this morning that I can't attend, but I have 3 this afternoon. Tomorrow, I think I have 5 I have to attend. And then Thursday morning, there's a couple. With that being said, Thursday afternoon into Thursday evening, and then I can meet in the evenings, the next couple of nights. I sent a couple of people that wanted to meet today, messages back that said, if you want to meet tonight, that's fine, later. I'm on East Coast time now. So I can meet later on tonight if you guys want to take advantage of that. So you can email me, but there's a lot of people that I wouldn't say blow me off, but they kind of do after exams when I request to meet with them. It's up to you. I'm not going to chase you around, right? I mean, we're all adult learners here, and you yourself know if you prepared adequately for exam 1. Only you know that. You know, my part is to teach you the concepts, to provide you a study guide, to offer you a review session, and any time to meet with me to go over anything if you don't understand it. If you take advantage of that, great. And students do, definitely do. And if you choose not to take advantage of that, that's totally up to you. So I sent you an email, whether you're above 78 or below 78. I'd like to meet with everybody below 78, but know that if you did well, if you were above 80, even if you're in the 90s, I had a lot of students in the 90s. If you did well, but you still want to see the 4, 5, 6, 7 questions you might have gotten wrong, I'm happy to meet with you as well. Happy to. I'm happy to meet with anybody, actually. My priority is the below 78 students. So with that being said, give me some feedback about exam 1 and your preparation. What did you guys think? Was it harder than you thought? Was it, if you attended a review session, was the exam what the review session covered? Give me some feedback, please. I would like some feedback. So I'll start with Bethany. Bethany, what was your feedback?
I mean, the reviews really went along with the exam.
Okay. Okay. Kylie, what was your feedback?
Honestly, I'm not gonna lie, I had a lot of trouble the first few weeks trying to get all 3 classes together. So it was hard to struggle like time-wise. The reviews did go along, I feel. It's just
Okay.
trying to get time-wise together, so.
Okay. Thank you. Sarita?
Good morning. I'm sorry.
Good morning. Good morning.
Well, I had time when I was in the hospital with my son. I read the review, the paper, the exam thing about 4 times. That's how I do stuff,
Okay.
and followed right along.
Okay.
Oh,
All right.
and I watch your video too.
Did that help?
Yes, ma'am.
Okay. Lashana?
The reviews did go along with the like everything, the session, the review, PowerPoint, or everything went together. I did go back and look at the PowerPoints a few times,
Okay,
but yeah.
okay, great. Christy?
I felt pretty confident going into the exam.
Mhm.
I mean, I know there's some things that like they kind of cross paths, so it's a little confusing. But I mean, time management is an issue, and then also trying to, I don't know, figure out how to jump back in the swing of things after being off the boat for 6 months
Yeah.
is pretty trivial because the ways that I was learning when I was in the program before don't seem to be working right now. So it's like trying to figure out what's going to work now, because it used to be before I'd rewrite the chapters and that
Right.
was like solid. It's not working. So it's
So
just trying to everything.
schedule some time with me and we'll talk about strategies.
Okay.
All right. So, yeah. And the other thing about exam one is we don't have to meet in the next couple of days. I mean, if you want to, we can do it late in the evenings. But if you want to wait till the weekends, I'm available on the weekends as well. Okay. I work 7 days a week with this job. So if you need a breather and get through this week with all your classes and want to meet with me over the weekend, let me know. I'm happy to do that.
Thank you.
You're welcome. And that goes to everybody. Shaylee.
I felt prepared going into the exam, but then the exam review that I attended, she added a lot more information than what you had given us. And in the end, that's kind of like what I studied, and it didn't help me at all.
Okay, that's good feedback. Rosie.
I really liked your color-coded study guide. That was a big help. And then knowing attending your live review and having you go over it with us and having everybody participate. I like that part.
Okay, good. I'm glad that helped. Diana.
Yes, ma'am.
Your feedback, please.
Okay, so with me, it was I actually watched I think I watched 3 different recordings that what actually helped me. I'm not gonna lie, because like reading it was confusing for me.
Okay.
But when I was actually looking at it with the PowerPoint helped me a lot. That's what I
Okay.
actually studied.
Good.
I don't
Okay.
know if that will help anyone, because when I was reading the book, it was like, because I have other 2 classes, so my mind was everywhere. I was like, let me just stick to the PowerPoint. So that worked
Okay.
for me. So
Good.
I don't know.
Good.
I believe it worked for everyone. Because it
Okay.
was really good.
Good. Great. Melina. Melina.
Yeah.
Go.
I think that the exam reviews were helpful. I guess like the problem I had on the test mainly is I feel like really good about certain questions, like I know this. And then like the priority questions can just get like confusing, like choosing the best answer.
Yeah. Andy.
I thought the exam reviews were really straightforward, which is the way that I study best, to have like a study guide that's straightforward, explains everything the way that it should. So I think that it helped me a lot.
Good. Okay. And then Jamie.
Yeah,
I can't hear you. I can't hear you. Yeah, Jamie, I can't hear you. Your voice is muffled. Jamie, if you could just maybe put it in the chat and give me your feedback, that'd be great. Okay, because I can't hear you. Okay, well, thanks for all that feedback. I'm always looking for feedback. And again, I will continue to say that I believe our study guides are an excellent representation of the essential knowledge that we cover in the chapters during the weeks. And The study guides are a good reflection of the knowledge that's expected that you need to know for the exam. So, you know, again, like I said, you guys know what you did, know how you prepared and whether you put the time in. And your score is probably a reflection of that. So I'm here to support you and help you moving forward. As far as the at-risk meetings, the next chance you have to bring up your grade, if it's below 78, is not till week 6 for our exam 2. Okay, so you will be considered at risk for the next 3 weeks with your campus deans. And then I have to do the reports every week. So I'll be continuing to fill out the at-risk reports that will now include homework and late assignments or missing assignments or everything's in. So anyway,
Speaking of homework, I tried to do the case study last night and it's like saying it wasn't loading. It just would say like, sorry, can't load, or just like, sorry, and it wouldn't let me get to it.
is this the hospice case study?
Yes.
Okay, why don't you stay on after and we'll try and sort that out.
Thank you.
I had that
And
same issue this morning.
okay.
Mhm.
Okay, stay on after. I want to welcome Dean Brown, who's just joined us. Good morning, Dean Brown.
Good morning.
Good morning. So does anybody have any questions about the exam? And reaching out to me to schedule some time to review. Okay, I appreciate all your feedback with regards to study and preparation and the reviews. The only thing that's discouraging is the lack of attendance at the reviews. I have 3 of you that attended live reviews in this class. So there were 8 that didn't. So we offer them for every exam, and I continue to encourage you to attend the live sessions. Okay. Before we get started with the chapters, I wanted to review with you guys the vulnerable populations assignment. Okay, has anybody had a chance? I know I mentioned it in week 1. Has anybody had a chance to take a look at the vulnerable populations assignment? It's due in week 9, so the instructions for it are in module 9. So I'm going to share my screen and we're going to go take a look at it. Has anybody had a chance to review it, just by show of hands? Okay, so like I mentioned in week 1, this is not a assignment that you start in week 7 or 8. This is why we're reviewing it in week 4. Okay, this does take some legwork, some research, and some organization. So I highly suggest you start in the next week or 2 working on your vulnerable populations assignment. Let me go in and we'll review it real quick. Okay, can everybody see my screen? Yes?
Yes.
Yeah.
Okay. Okay, so this assignment is worth quite a bit. It's a very important assignment for you guys to pay attention to. And as always, before we talk about assignments, I need you guys to review the rubric, okay? Because the rubrics are what I use to grade your assignments. So I would first start with taking a look at this page and then review the rubric to see what's required. Okay, so you're going to be selecting a vulnerable population in your community. Okay, you're going to be doing a survey within your community. Okay, we call it a windshield survey. Windshield survey is completed by observing a population by looking out your window or your bike, if you're on your bike, or riding the bus or the train. Okay, so you're going to be identifying a vulnerable population. There are some samples, there are examples right here below. Okay. If you're going to use any other population outside this group here, will you just let me know? I would appreciate that. Okay. So you're going to be identifying a vulnerable population in your community, and you're going to be conducting research on this population via the internet and phone calls to a local health department. You're going to be developing a PowerPoint, maximum of 10 slides, to communicate your observations and research. Okay. So I just want to point out that there are specific requirements of this assignment. Okay. And here are the bullets. Okay. So what I noticed last term was, let's say, people picked poor and homeless persons. Okay. So their PowerPoint was giving me research on national statistics of poor and homeless people. Okay. Or if they picked pregnant adolescents, they were giving me, what's the statistics nationally? What is it about? What's the research? Who's vulnerable? Okay. This assignment is specifically asking you to identify a population in your own community. That's what we want to know about. Okay, I don't want to know about severely mentally ill individuals, national statistics and research about that. I want to know about a program or an area in your community that takes care of this vulnerable population. Okay, several students got that incorrect last term. Okay, and if you look at the rubric, if you're not identifying a specific population in your own community and talking to people at the health department, talking to people in the rehabilitation center, talking to people that are part of the resources for these vulnerable populations, you're not going to get that part of the rubric. You're not going to get those points. So please, please take a look. So you're going to be identifying the population, identifying the health risks and the needs of the vulnerable population. Okay, you're going to be identifying the resources that are available. You're going to be describing service gaps, interventions that could be used, specifically asking for primary, secondary, and tertiary resources that could fill the gaps. Okay. So there are 1, 2, 3, 4, 5 specific bullets. So please, please take a look at that. Okay. And then if you, the proper filing name is right here. Okay. So that's how you're going to save your assignment. Okay. So does anybody, oh, here's some other, this goes through the 5 bullets up here. Okay, so here's your research. Here are the things to address if they're applicable. Okay, health, population, research, health risks, resources. So here's your guide, step-by-step guide right here. I just need you to follow it. Okay, and then here's some references. Not the only references, it's just a start. Okay, it's worth 60 points. And here's your rubric. Right, so to get 10 points, you need to, well, I'm not even going to finish that. Read the rubric, follow the rubric. Okay, So to get your 10 points, it's asking you to identify all these areas. Okay, this is a big project. Okay. Questions? Nobody has questions. Okay. All right. Okay, quick update. Has anybody had a chance to review the PowerPoints from last week, from week 3, 22, 23, 24, and for this week, 29 and 30? Has anybody had a chance to review anything? Does anybody know what we're covering today? What are the topics we're covering today?
Is it the rural health and migrant health and stuff like that?
That's from last week. Yep. And we're going to go through that. But
Hospice care, right? Home health and hospice.
Faith, community. Right? Okay. So let's go back and review last week's information. Okay, just bear with me for a sec. Okay, when you think of rural health and migrant health, what do you think about? What do you think about? What kind of populations do you think about?
Farmers.
Good. What else?
The Amish.
Good. What else? What else comes to mind?
People that weren't born in the United States.
Okay. I'm just trying to pull up the textbook here. Okay. So let's go back to the PowerPoint. Sorry about that. Okay. Do we think access is an issue? Can access be an issue with migrant and rural health?
Yeah, there's not very many hospitals and healthcare facilities.
Correct. Okay. And what issues does lack of access create?
A lot of health issues because people don't have access to it, so they tend to like self-medicate.
Okay. Okay. Other issues to access, well, rural and migrant health creates problems with access because there's also a lack of specialty healthcare professionals, right? Your family doctor in the rural community may be the labor and delivery doctor, maybe the pediatrician, maybe the adult health provider, right? Elder care provider, right? What are some differences in rural versus urban? What's the difference in rural versus urban?
Urban has better access to healthcare.
Okay. Okay.
Urban has more people.
Okay. And so are they going to have better access?
Yes.
Yes. Right? And moving to rural areas is becoming is becoming more popular. Why?
I'm sorry, can you re-say that?
I said moving to rural
The
areas
cost of living.
is becoming more popular. Why is that?
It's quiet.
The cost of living.
Okay. Okay. Anybody else want to jump in? Since I'm sharing my screen, I can only see a couple of you. So please jump in. Okay, let's take a look. What do we think the population characteristics are and the cultural considerations are for rural populations? What do you guys think? Do you think families or populations in the rural community tend to maybe have higher poverty levels? Have higher uninsured levels?
Yes.
And why do you think that is?
Just they lack the access to things, as far as like I remember I read something about in a lot of the rural areas they had trouble with the elderly, as far as like their medication. They was taking it improperly, but they didn't have the internet, so they couldn't use like telehealth and stuff like that. So you
Yes.
know, a lot of this medication is in medical terminology, and they had trouble even comprehending how many times to take the medication a day.
Well, and that's the issue with access we just talked about, right? Lack of access to the internet. Right?
For too.
Pardon me?
Like you said earlier, it's cheaper for them, so
Mhm.
they're not gonna spend the money on the things that they obviously need in
Okay.
healthcare. They're gonna be more worried about whatever
Mhm.
business they have or their home life theirs.
Mhm. What do we think the health status is or will be of rural residents? Do we think, well, we know that they definitely have a poor perception, right, of overall health.
They most likely are not gonna go in and area, like.
Say that
there's-
again, Kylie?
Sorry, I'm at school, so there's
Okay.
people in class too. But they're most likely not gonna come in for anything unless it's like super serious.
Mhm. Yep. And what we do know as well about rural is that they are much more likely and have higher incidences of chronic diseases, right? Heart disease, COPD, hypertension, right? And we do know that they tend to definitely, they have, they're very much compromised with their health, and they are much less likely to seek medical care. I mean, that's just a fact. Right? And then if they need to see a specialty care provider, right? They're traveling. A lot of people in the rural community have issues with transportation. Right? So they may not be able to get down to the cities to see the specialist. Okay, and then the healthcare providers, right? There may be one provider for several different counties or several different communities. Right? You always see nursing positions advertised in the rural communities. It's hard. It's hard to be a nurse up in the rural and migrant communities. Why is that?
A lot of travel and the lack of access makes people more leery about healthcare and the practitioners, so they don't trust them.
Okay, good. What else? I have a couple of thoughts, but go ahead, keep going. I mean, you kind of have to be the jack of all trades.
I believe
Go
because
ahead, Sarita.
that's what I was saying, like far as like education wise, they probably don't have like a lot of colleges where people can become nurses. So you have to bring them in, and a lot of people don't probably want to come live in that type of environment, you know, that area. Because like you say, you'll probably be a nurse for the whole town. Yeah.
Right. There's an example in the book of a nurse that she can't get a break anywhere. When she goes to the grocery store, she sees her patients. When she goes to work, she sees her patients. One of the big issues is the lack of anonymity out in the rural communities, right? Everybody knows everybody. Right. And one of the things that happens with that, well, I think that's coming up, but we'll just talk about it now, is the lack of anonymity. Everybody knows what everybody's doing. So in the rural community, there is much less of a chance that people are going to report certain things like domestic violence or drug abuse or alcohol abuse. Why do you think that is? Because once somebody knows, does everybody know?
Yes.
That's just the way it is in the rural community. So going back to the nurses, it's a hard job being a nurse in a rural community, right? You have to bring, it's not like you're working on the pediatric unit at the hospital or the stroke unit and you have a specialty of care that you have to focus on. If you're the nurse in the rural community, you're doing everything, right? You might be the public health nurse, you might be the immunization nurse, you might be the labor and delivery nurse, school nurse. Does that make sense? You have to bring all your skills together, right? Because remember, what is community health about? We're caring for the entire lifespan, right? So you're caring from infants all the way up to the elderly. So it requires a lot of skills, bringing in, your med surg and your maternal child and your mental health. What do we think about mental health in the rural communities? Are people in the rural communities much higher risk for mental health issues?
Yes.
Yes.
Why is that?
They struggle in ways that people in urban communities don't. Especially with the
Right.
cost of living, it's less, but their income tends to be less as well.
Okay.
There's not enough resources for them either.
Yeah, excellent. Yep. Yep. And remember, there's a much higher rate of poverty in the rural community, right? And as we talked about last week, poverty affects what? Everything. Everything. We talked about that. The most significant effect of how to establish the health of your families, wherever they are, urban or rural, is what?
The windshield survey?
Well, the financial stability, the financial health of a family, right? We talked about that, how it dictates every other facet of their lives. And then put that family, a family in poverty, into the rural community, and things are exacerbated, correct?
Mm-hmm.
Yeah.
Yes.
So, go ahead. So with regards to women's health in the rural communities, specifically maternal and infant health, we definitely have a higher infant and maternal morbidity rates. We have a high proportion of racial minorities and fewer specialists, right? There are definitely variations in pregnancy outcomes, right? And particular risks for women live on or near Indian reservations, migrant workers, are of African American descent and live in rural counties of the states in the Deep South. And lastly, are victims of sexual assault. Those are some pretty significant risks. Why do we think they may have a higher infant mortality and morbidity?
Lack of prenatal care.
Yeah, what else? What barriers might prevent them from getting prenatal care? You know, what if they're a high-risk pregnancy? And there's not a high-risk OBGYN, and they don't have transportation. Those are the many hats that the community nurse, rural community nurse plays. What would you do? Well, let's just take that for example. You are the public health, community, rural, migrant nurse, and you have a high-risk pregnancy. Is it up to you to know your resources, know where to find the resources for this family? And
Yes.
network with other communities, other public health departments? What do they do? What physicians are available to guide you? Because a lot of times you're on your own. Okay. And then let's talk about kids in the rural community. How are they at higher risk?
Probably for childhood illnesses due to like not being able to get certain immunizations.
Mhm.
Yeah.
Yeah. What about the kids who work on the farms?
They're exposed to more hazards.
Absolutely. You know, kids may not have regular, you just said it, Kylie, may not have regular appointments with the pediatrician. So therefore their vision isn't getting checked, their hearing isn't getting checked, their, you know, height and weight isn't getting checked, what else isn't getting checked? They may not be getting their immunizations. You know, if there's any kind of developmental disability or anything like that. You know, just the access of those services is very limited. And as a rural nurse, you're in a position where you're also the educator. Remember that box we looked at last week that said all the potential roles that the community health nurse can play? And we talked about, depending on what situation you're in, you may be wearing 4 of those hats, or you may be wearing all 12 of those hats. Well, in rural health, how many hats are we wearing? Probably 12. Right? It's hard. Okay, mental health, we touched on this a little bit. It is typical for the rural population to delay seeking care. Right? Very high rate of depression. Okay? Which goes with, we just talked about that, poverty, maybe the isolation of living in the rural areas, and the lack of resources. You know, the other issue that's also prevalent in the rural community is domestic violence. Alcohol, tobacco, and other drug use as well. Okay, some occupational and environmental health problems in rural areas. What do you think we're looking at? Think about it. You're up on a farm. What are your risks in the rural community?
Exposure to those pesticides that cause cancer.
Yes.
And then the minor, as far as like respiratory issue, the colds, you know, getting to their lungs.
Yep.
Heat and sun exposure.
Exactly. Good. And some high-risk industries that are primarily found in rural areas: forestry, mining, fishing, agriculture. This is in the book, but I'm just going to add to this. But one of the big risks in the rural community as well is the risk of accidents. Right? Not wearing your seatbelt, farm equipment. Just kind of laissez-faire attitude about safety precautions. Okay, so some rural healthcare delivery issues and barriers to care. We've already talked about most of these, so good job, you guys, identifying these. Some barriers, right? The availability, which was access, the affordability, right? And the providers, right? The providers' attitudes, insights, and knowledge. I mean, we talked about it. You may have a family doc that is the baby's doctor and your grandparents' doctor. So what did we talk about last week? What's one big, huge job of the community nurse? What does that mean? Designing community health programs. One of our biggest jobs is education, right? Think what opportunities would we have for education in the rural community? I mean, the list goes long, but I mean, we have such an opportunity. What could we be teaching our populations in the rural community? I can only see 3 people, so I need you guys to jump in, the others. I can only see Bethany, Kylie, and Sarita, so I need the rest of you to jump in. If you are the rural nurse, and we've just gone through all about rural population, and education is a huge part of our job, our role as a rural nurse. What are we going to be educating these families about? Nothing?
Kind of a little bit of everything.
Pardon me?
A little bit of everything.
A little bit of everything. For example, give me a couple of examples.
Healthy lifestyle.
Absolutely.
Healthy eating habits. Maybe even stress. Like mechanisms to handle stress better.
Perfect. That's great.
That has safe precautions too, like especially if they're on a farm, like if you're having a 5-year-old kid outside on a farm, what precautions are you going to set for them? Or I mean, they kind of just expect their kids just to go out and do it, but not every kid is meant to do that stuff, so it's a lot of tough work.
Yes. So we just reviewed the risks, and so your education would be focused on those risks, right? We said that domestic violence and mental illness and alcohol abuse are prevalent in the rural communities. So could you focus education around that?
Yes.
Okay, so let's take the at-risk population in the rural community. Let's say domestic violence. Okay, let's identify a primary, secondary, and tertiary prevention for that particular population. What would be a primary? What's primary?
The prevention.
Okay, so what would be a primary intervention if we're working with a mom who's involved with domestic violence with her partner? Or no, let me take that back. We're talking about primary. So what would we do for primary?
Would it be
Teaching the signs and
identifying?
symptoms of domestic abuse.
Yeah.
Exactly. So maybe you would do a community in-service or a community education program about the risks of domestic violence, right? Remember, we're trying to prevent anything before it's happening, right? It's like we talked about last week, getting into the high schools and teaching these kids the risks of obesity before they even get there, right? So this is the same concept. We're trying to educate the rural woman that yes, domestic violence you're more at risk for it, but here's ways you can prevent it or recognize it. Okay, great. Secondary, what's secondary?
Screening.
Screening, yep. Yep. So what could we do? What could be a secondary prevention for that?
Talking to someone and recognizing the signs, like asking them what they do, you know, when they're dating, like how they have fun.
Excellent. So remember, secondary is early identification, early intervention. We're trying to screen who might be more at risk or who is at risk and working with them. Great. Okay, tertiary. What's a tertiary? What has to happen for you to be putting tertiary interventions, measures in place?
It's already going on. They're already suffering.
Okay. So what is tertiary about?
Getting them out of it.
I was
Right.
telling them access to shelters or, yeah, like you said, ways to get out of it.
Good, you guys. Good, good. That's perfect. It's perfect. So the issue is already going on. Okay. Let's shift to migrant health real quick. Health of minorities, particularly the migrant farm workers. Okay. So what are some issues in migrant health? A lot of it's the same as rural, but there are some differences. So here's some issues in migrant health. Why do we think there might be increased issues with migrants? Language barrier, lack of knowledge about how our services work. They can't afford it. What else? It's on your screen right now.
Domestic violence.
Domestic violence, depression. We've already, look at how similar this list is to the rural population. Well, I mean, technically they're working in the rural population. Okay. Documentation, transportation. I want to go back real quick when I asked you guys about, as a nurse educator, the rural health nurse, one of the things, we said this at the beginning of the lecture, that is prevalent, hugely prevalent in the rural population is the issue of chronic disease. So you would be doing a lot, not to jump back, but you would be doing a lot of education around chronic diseases. And if chronic diseases are prevalent, that means they already have the diseases. So your education, what would it be? Primary, secondary, or tertiary?
Tertiary.
Right, because they already have the chronic disease. And so what are you trying to help them do? Manage it, decrease the complications. What?
Improve their quality of life.
Yeah, exactly. Exactly. Okay, so issues in migrant health, there are some differences, but they look very similar. Okay. Cultural considerations in migrant healthcare. We haven't done the cultural competence chapter yet, but just common sense would tell us that as a, well, any kind of nurse, but a rural nurse, migrant nurse, are you going to be dealing with cultural issues?
Yeah.
And so how are you going to successfully, interact with and develop a relationship with migrant families to help them live their normal lives, live their daily lives? What needs to happen? As a nurse, what do you need to do proactively?
You need to educate yourself on various cultures, ways to interact with them, and find mechanisms to build rapport.
Excellent. Excellent. Yep. So we do need to be aware of their cultures, their values, beliefs, their practices, right? So here's a summary. Nursing care in the rural environments. I think we've probably already talked about most of these. Community-oriented nursing needs to vary by community. Do we remember from exam 1, what is the difference between community-oriented nursing and community-based nursing?
Yeah, I get those two like mixed up.
Okay. Remember the example, do you remember the example I gave you of how I remember it?
Community based, you already there.
Correct.
Community oriented, you going in to learn about it.
That's exactly right. Thanks, Sarita. I look at it as you're orienting yourself about the community, right? The population, the risks, the barriers, right? Do you remember that? We talked about that last week. Community oriented, you're orienting yourself to the environment. Community based, you're based in the community, right?
Okay.
Remember talking about that last week? We're based in the community.
Vaguely.
We're working in the community. We're taking care of the ill. We're taking care of chronic diseases. Okay, and we know that's obviously going to vary by community. The community-oriented assessment is going to be different community to community. Okay, so there is needs in most rural communities, especially for the following. So this is a common list of the needs for the rural nursing. School nurses, family plan. So a school nurse, family planning nurse, prenatal care, care of individuals with AIDS and their families, EMS, kids with special needs, mental health services, and services for older adults. So here's all those hats. Remember we talked about all those hats? You may be it. You may be doing all of this. You may have a couple of partners that are doing some of that, but rural nursing is very challenging. I mean, that's a lot of areas to know if you're the only one, right? Like that nurse example in the book, the nurse said, I can't go anywhere without seeing my patients. My kids go to school with the parents, and yeah. Does that make sense? The lack of anonymity. Everybody knows everything. So case management. What's case management? We haven't gone through that chapter yet, but what do we think case management is? You're managing cases, right? You, the nurse, are the case manager. You are the coordinator of care. This is important in the rural community. It's important everywhere, but I always consider nurses, I think we case manage all the time, right? We're case managing everything about our lives. We're case managing our family. We're case managing our job. We're case managing school. You're in charge, and you're the coordinator of care. Okay, it's important in the rural communities because you will be the case manager. You will be the one that's coordinating care, right? And so here, we would define the community, which is the community-oriented approach from the last slide. We would identify the community's health problems. And then we would develop our plan. Remember ADPI. What did we talk about last week? You have to be able to take your ADPI from your pediatric patient in your hospital, clinical, and shift your ADPI into the community. And we talked about several examples last week of how to do that, right? So let's go through ADPI real quick in your assessment of the new job you just took as the public health rural community nurse. Okay, what's your A? Hello, what's your A in ADPI?
Assessment.
And so what are you going to be assessing in the rural community?
Lifestyle, safety, finance.
Yep. Okay, what's your D?
Diagnosis.
Okay, so what does that translate to in the rural community? You have what? Identified So instead of diagnosing your pediatric patient with asthma, you've now diagnosed your community with what? Whatever issues are going on, right? You have to be able to transfer your thinking process of ADPI from the inpatient setting into the community. So diagnosis, we have, after our assessment of the community by doing surveys or whatever you're going to do, we now have a list of the second bullet here, identifying the community's health problems. Okay, what's P?
Planning.
Okay, so what do you do now? You've assessed the community needs. You've diagnosed, you have come up with a list of what the community issues and needs are. So what are you going to start doing? Right here, number 3.
Making a plan to address the needs.
Exactly. Develop or modify health services in response to the needs. Okay. What's I?
Implementation.
So what are you going to be doing? You're going to be implementing what Bethany just said. You develop a plan. I think it was Bethany. I can't see. You develop a plan of what your community needs. Implementation is you carry out that plan. Right? And then what's E?
Evaluation.
And what do we do in evaluation? What does evaluation mean? We see how good
you're working.
We see how good our plan is working. So do you see how we just took ADPI into the community? Well, actually, we took it even further. We took it into the rural community. That's what I need you guys to think. That's how I need you to think. Okay? And you have to be able to take your ADPI into the next topic, the faith community, the hospice nursing. So we just did it for rural. Does that make sense?
Mm-hmm.
Okay. Potential use of technology for the rural, connecting with rural providers, right? Texting messages, telehealth, we've all seen that. What have we seen over the last 18 months with this pandemic?
A nightmare.
Yeah.
Oh, telehealth.
Sorry.
Yeah. Right. Video health, telephone health, right?
Yes, less in person. Like,
Exactly.
yeah.
Exactly. Okay, I want to keep moving because we have other topics to cover. Was that helpful? Do you have a better understanding of rural and migrant health?
Yeah.
Anybody have any questions? Okay,
Mhm.
let's keep going. Okay, we're going to go into chapter 23 now. Okay, so this is now we're starting to get into vulnerable population. Well, we just covered vulnerable populations in the rural community, but in society itself, we're going to cover poverty, homelessness, teen pregnancy, and mental illness. Okay, these are the 4 prevalent groups that we're going to talk about. Okay, these are 4 groups of people who represent members of vulnerable populations: the poor, the homeless, pregnant teens, and those who are mentally ill, because we do know that they will present with very complex needs. And it doesn't matter what area of nursing you're working in, hospital, clinic, schools, parish, you are going to have to care for these vulnerable populations. You're going to be exposed to, they will be in your path. So we need to learn about them. Okay. And we need to understand our own beliefs about these groups. What do you think? What do you think when you're walking down the street and you see homeless people? What are your beliefs about that? So these are hard. Next couple of chapters are hard. They're hard. Okay, nobody likes to see these vulnerable populations. Nobody likes for people to be homeless, you know, mentally ill, addicted. This is hard stuff, but we're nurses. We're going to be caring for patients like this. Okay, so we need to identify the healthcare needs, the barriers to care, essential health services for each of these groups. Okay, so as always, everybody's got their own attitude and beliefs about everything, right? Right? We have our, we think about, you know, why are they doing that? Or how did they get there? Or how come they can't get better? Right? So really when caring for these significant for vulnerable populations, we do have to consider our personal beliefs and attitudes and our perceptions. All right, because they are going to affect how we care for the patient and their families. And remember, what's the other thing about community that's different from your pediatric asthma patient? In the community, who are we caring for? The whole family, right? It might be an individual who, you know, an individual teen who is pregnant, but we're going to be dealing with the whole family, right? That's why community, I keep bringing you guys back to community nursing. It's such a big umbrella, and I'm trying to kind of stay focused into these PowerPoints of what we need to know. Okay, because there's so much information within community nursing. Okay. All right, poverty. Poverty and homelessness affect people's health status, right?
Yes.
And the book has a good paragraph on the definition of poverty. Okay, as far as how do you identify federal income poverty guidelines. I'm not going to go through that. I suggest you go back and read through that, but it is important to understand what the definition description of poverty is. Okay, it may be individual poverty, it may be family poverty, it may be a community poverty, right? Neighborhood poverty. Okay, but poverty, for purposes of this class, poverty is the biggest determining factor of what? Everything. Everything. It affects everything. Do you remember me honing in on this last week? Financial stability, family health is dependent. Poverty is dependent on the financial health of the family. So if you are living in poverty, what things, what factors could be affected? Okay, or what does a community that's living in poverty look like? Or a family, maybe decreased earnings, increased unemployment rates, changes in the labor force. You can read through this. All right, I want to keep moving, but I do, if you haven't had a chance to review these PowerPoints, there's a reason why I send them to you early. I send them to you the weekend before class, just because I want you to review it and be prepared to talk about things in class. Because if you haven't looked at it and I'm just presenting it now, then this is all new information for you and it can get overwhelming. Okay, and we talked about last week, it would be so helpful for everybody to review PowerPoints before coming to class. If you have, thank you. If you haven't, then I know we're covering this quickly. I would suggest that you go back after class or when you have a minute and review these. Okay, so poverty and health, what are the effects across your whole lifespan? Chronic illness, right here, slide 8, chronic illness, higher infant morbidity and mortality, shorter life expectancy, more complex health problems, right? More debilitations or limitations resulting from your chronic diseases. Okay, what else? What else does poverty and health affect across the lifespan? What else? That's a short list. What else can it affect? I need you guys to jump in. What else can it affect? What about kids? Kids in poverty. How does that affect their health? They may not get
How
to
they
their,
develop,
yeah.
yeah,
Well,
like
I
their
mean,
developmental pace.
yeah.
Higher
Think
chances
about,
of infection.
yep. And we're talking all across the lifespan, starting from pregnancy, right? If you're living in poverty and you're a high risk pregnancy, you may not get the prenatal care that you need. And that starts the process from birth on, right? And then kids may not get their immunizations, their pediatric appointments, right? Poverty has an especially negative effect on women of childbearing age, adolescent women, children, older adults, and both urban and rural communities. It affects everything, right? How do we understand the concept? What is the concept of homelessness? Okay, so now we're getting specific. All right, so we know that poverty can lead to homelessness, right? And how have you guys read about how do we know how many people are homeless? Okay, so if you looked at this ahead of time, you would know that there's two common ways to determine the number of people who are homeless: point in time counts and period prevalence counts. There's different kinds of poverty. There's crisis poverty, there's persistent poverty. And then this is an excellent slide, slide 11. What are the effects of homelessness on health? Well, you can read through these. Infections, infestations, hypothermia, peripheral vascular disease, diabetes, TB, HIV/AIDS, trauma, mental illness. Okay, let's talk about teens, adolescent sexual behavior, and pregnancy. Why are adolescents so at risk for teen pregnancy, domestic violence, drug use? Why?
Don't get educated on it. They get like prior to when they do it.
Mm-hmm.
I believe at that time, well, at that age, you're looking for more acceptance from your peers, so you're more likely to participate in underage sex and drugs, and more accepting of the abuse of boyfriend, thinking it's love.
Mm-hmm. Well,
They
we know
usually
that.
think they're invincible.
Pardon me?
The teens usually think they're invincible.
Exactly.
It'll never happen to them.
Right. And we know by just, it's a fact that teens are much more risk takers, right? Okay, some issues, I want to address this right here. This last bullet on slide 14. Some issues in caring for the pregnant teen. Violence, prevalent. Nutrition, prevalent. Infant care, prevalent. Prevalent risk factors. Okay? We know that teen pregnancy, they're at a much higher risk for violence, poor nutrition, lack of infant care, and schooling and educational needs. right? Okay, let's look at the third one, mental illness. Or was this the fourth one? This third one. We did homelessness, pregnant teens, mental illness. Okay, what do we know about mental illness? Let's just talk about mental illness in the last 18 months. Why? Why is there a huge prevalence of mental illness? Let's just talk in the last 18 months. I'll start. Isolation. What else? Don't make me start calling on people. Why is there an increased mental illness over the last 18 months?
COVID.
A lot of people lost their jobs.
Correct.
They're homebound.
Correct.
Stress levels increased.
Yep. What about kids? What happened to kids?
Like
They couldn't
everything
go
At
to
home.
school. They couldn't be around their friends.
They're home.
Like an
Social
abusive household.
isolation.
Mhm.
Yeah. What if they're at home with a parent who is an abuser?
suicide rates went up.
Suicide rates climb dramatically. Okay, so mental illness is a huge issue in this country. It's a huge issue everywhere. And over the last 18 months, it really has reared its ugly head with so many additional issues because of the pandemic. And I know this because I work in the schools, or I did work in the schools for 20 years. The last year and a half in the schools was absolutely shattering. From preschool kids all the way up to 12th graders, are the kids I worked with. The mental health issues exponentially exploded at all these age levels. Okay. Okay, levels of prevention. I want you to star slide 16. Okay, we need to go through this. What are some levels of prevention, primary levels for this population, these vulnerable populations? Okay, so Sarita, why don't you read us the primary prevention?
Primary prevention services include affordable housing, housing subsides, effective job training program, employer incentives, preventative healthcare services, multi-system case management, birth control services, safe sex education, needle exchange program, parent education, and counseling programs.
What do all these have in common?
They're preventative measures.
Education, prevention,
Mhm.
right? All right, Andy, read me secondary, please.
Secondary prevention activities are aimed at reducing the prevalence of pathologic nature of a condition, i.e. supportive and emergency housing, soup kitchens, and screening for depression.
What do they all have in common? Secondary. Early identification, early screening, right? And then Christy, read us the tertiary, please.
Tertiary prevention attempts to restore and enhance functioning, i.e. support of affordable housing, promotion of psychosocial rehab programs.
So what does tertiary have in common? The
Ways to
issue,
make it better.
yep, the issue's already there, right? They either have a mental health issue, they are homeless, right? So what are we trying to do? We're trying to restore, we're trying to prevent things from getting worse, right?
Yeah.
Okay. The role of what's our role in caring for these populations? Create a trusting environment. That can be hard. That can be hard. Why is creating a trusting environment with a homeless, a pregnant teen, somebody with complex mental health issues? Why could that potentially be so challenging? Take a look at the screen in front of you. right? They may not trust, they may already be in such a bad place that they don't trust anybody.
They're scared.
They're scared, right? Takes an extra special person, nurse, to really work deeply with these populations. I worked for a couple of years in Denver. It's called Father Woody's, which is a shelter for the homeless. Did a lot of volunteer work there. If you haven't done volunteer work for the vulnerable in your community, I highly suggest you find a cause, and maybe you will come out of your vulnerable populations assignment. I don't know, but if you haven't volunteered your time in your community with a vulnerable population, you're missing out on a lot. There's so much we can do, so much. Has anybody done that in their environment, in their community?
Yes.
What have you done? And who's talking?
Homeless shelters, soup kitchens, and I do a lot with the Salvation Army.
It's awesome. It's awesome. Anybody else do any volunteer work or any charity work in their communities with vulnerable populations?
Yes. We do for underage kids, well, underprivileged kids for the holidays. My cousin, he was the city councilman and he's the vice mayor, and he does this big Christmas drive, and we try to do 200 bikes. It's just for also for like getting kids out of the house and going outside to, you know, exercise. So we do it every year.
That's awesome. Yeah, if you haven't had that kind of experience that Sarita and Christy just described, it is heartwarming. Whatever cause that you are helping to lift up, and take as many people along with you. It's just an incredible experience. So the role of the nurse working with these significant vulnerable populations, that we have to create a trusting environment. We need to check our own values, right? We talked about that at the beginning. Check our own values and thoughts about the population, show respect, compassion, and concern. Nobody wants to be in the situation they're in, right? Okay, nobody wants to be told why you think that they are homeless. All right, well, this is where we don't make assumptions, right? As a nurse in a community, we need to know what our resources are, who our providers are, who we can direct these people to if they want to improve their situation. All right, focus on prevention, know when to walk beside the client and when to encourage the client to walk ahead. Right, and it can be hard. This last bullet is important. Develop a network of support for yourself. If you are constantly working with these populations, it can be very, very overwhelming. Make sure you take care of yourself. Questions? Is that helpful?
Yes.
Okay, let's move on to chapter 24, which is alcohol, tobacco, and other drug problems in the community. Okay, this is a huge problem. Huge. Okay. And I would bet that every single one of us, including me, has been involved with either yourself or a family member or a friend or a coworker with alcohol, tobacco, or other drug problems. And I bet most of us, including me, know people that have died of overdoses, right? Died because of alcohol abuse or drug abuse. Is that right? I'm yes on all of those. It's tough. This is a tough chapter. Okay. Right. So what is the scope of this problem? Right. We know that alcohol ATOD, just for purposes of this chapter, is alcohol, tobacco, and other drugs. Okay? So ATOD, abuse and addiction, can cause multiple health problems for individuals. Contributing factors can be anything. What drives them to this? Poverty, mental illness, lack of job. I mean, it could be many, many, many contributing factors, right? So, and again, cultures and beliefs. You need to check yourself at the door with these as well. You know, I followed a friend through rehab and stayed with her for 30 days, or at least was there with her in and out, right? The people that worked in this rehab center were angels from heaven. Okay. They were there. They wanted to be there. Their goal was to help everybody, including my friends, get healthier. Okay. And the one thing I remember thinking is these people that work at this rehabilitation facility were meant to be here. All right. Because we all know we have our beliefs and attitudes toward people who are alcoholics, people who abuse drugs, right? We tend to look at them as good or bad. Okay. All right, so we have alcohol, tobacco, and other drugs, substance abuse, drug dependence, drug addiction, and alcoholism, right? We know, you can read this on your own, but we have psychoactive drugs to deal with, okay? We have depressants to deal with, right? This just gives you a little synopsis on what each of these categories are. You can go back and read through those. We have stimulants. Okay, alcohol, tobacco. I really do want you to go back and read through these starting slide 6. Okay, I want you to go back and read through slide 6 through. This is just going through all the different kinds of drugs. Amphetamines, marijuana, hallucinogen. Okay. All right, so that's what most of this chapter is about, is going through what kinds of drugs are available that people are using. It's many, 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 many. And you're going to be working with these kinds of clients in the community or as patients in the hospital. Okay, so I don't think we need to review what each and every drug does, but we don't need to review it here today, but I want you to review it on your own. All right, so slide 6 through 17. Okay, so write that down on your notes. Review on my own, slide 6 through 17. Okay. Okay, let's go to our primary preventions with regards to alcohol and drug abuse, right? Primary prevention. What are we talking about? Education, promotion of healthy lifestyles and resiliency factors, drug education, right? That's what I did a lot of in my school nurse job. Lots of drug education with the high school kids. All right, teaching that no drug is completely safe. And my gosh, what you hear about these days is all of the drugs that are tainted with everything. Everything. I mean, it's so dangerous right now. Right? So we can do so as nurses, we can nurses providing primary interventions, we can promote healthy lifestyles, right? Assisting clients, patients to achieve optimal health, teaching, especially in the adolescent group and the high school group, teaching assertiveness and decision-making skills. You know, that just say no. Teaching stress reduction and relaxation techniques, and then drug education. Okay, this is key. I mean, we have a whole, in our huge district, we have 90,000 kids. We have a whole department on drug prevention. It's huge. And then secondary, right? What do we say secondary is? Early identification, early intervention, right? So we're trying to assess for these problems. Maybe drug testing. Who are the high-risk groups? The adolescents, the older adults, drug users, codependency and family involvement. So we're trying to screen who is the high-risk group that we need to work with, right? And then tertiary. The issue's already there. So now we're at detox, treatment, smoking cessation programs, support groups. In this chapter in the book, there is a box that is, it's a resource box for all of these. It has all of these in it plus more. I actually printed that out when I started teaching this class. And I can't tell you the number of times I've gone back to it to get a resource for a family member, a friend, somebody who's asked me. So go back into this chapter. This is chapter 24. And if you want to read a really good resource list, it's in your book. Okay. So what's our role? What's our role as a community nurse for this population? What do you think? And now I'm asking you, I want you to answer me. What is our role? Because you are going to be working with these patients and clients. So what's your role? I'm going to start calling on people.
To assist in prevention and to basically be knowledgeable regarding the resources within the community.
Absolutely. That's one of the biggest, is what are the resources available to these vulnerable populations in the community? And not only what the resources are, but what can you do? You're the community nurse. So what do we say community nursing is all about? Education, program development. So you can be developing community prevention programs. Right? Remember, we already said this, nurses are in an ideal position, ideal role to assist with tertiary prevention. Okay. So I want the one thing I want you to go back and review for that chapter is all the different kinds of drugs. Okay, let's go into the faith community nurse. What do we think faith community nursing is? Anybody know a faith community nurse? Two of my best girlfriends are faith community nurses. What do you think the role of faith community nurses in the community? Anybody? So, parish nurses work in close relationships with individuals. Oh, I'm sorry.
Would that qualify as like a nurse midwife, or that's like a nun, or like hype in the church?
Yeah. Parish nurses work in close relationships with individuals, families, and faith communities to establish programs and services that affect significantly health, healing, and wholeness. Okay. Faith nursing brings a spiritual aspect to community nursing. Okay. Parish nursing is actually very, very prevalent, very popular, right? So parish nursing is gaining prominence again as nurses reclaim their traditions of healing, knowledge, acknowledge gaps in service delivery, and along with rising nursing centers, right? All right, so when we talk about faith community nursing, that is wherever you gather. Okay, could be a mosque, could be a cathedral, could be a synagogue. Okay, that acknowledges a certain faith. So faith community nursing is wherever you practice and whatever you practice. Right? So faith is, so as parish nurses, right, they're very focused on health and wellness. Okay, in their particular faith community. Right? So there, you know, you have, it's part of their ministry. So the nurse is part of their ministry, as is their, I don't know, music program in the let's say in the church. Let's just say in the church. Okay, so the music program, the nursing services, the adult education, these are all part of ministries in a specific organization. Okay, so here's some, we're in slide 4. Here's some services that a parish nurse may do. She may be visiting the homebound. She may be providing meals for families in crisis when returning home after hospitalization. She may be participating in prayer circles, volunteering in AIDS care groups. She may be doing support groups. She may be serving suppers. She may be organizing health fairs, right? Grief support groups. This is just a short list. Okay. The two things I need you to understand is there's two models of community nursing. One is the congregational model and one is the institutional model. And we're on slide 5. Okay. And here's the simple difference between the two of them. The congregational model, the faith community nurse is working within the congregation only. Okay. She's autonomous within the, she is performing at the direction of what the goals are for the faith community, for that particular faith community. All right. The development of her role arises or is developed through what the needs are of that faith community faith. Right. She's accountable to the congregation and the governing body. Whereas an institutional model, a faith-based nurse can't provide every service. Okay, if she's providing just basic services, right? What happens to the parishioners or faith community members who need healthcare, who maybe need wound care, or need physical therapy, occupational therapy? Okay, so then that moves into institutional model of faith community nursing, where we are partnering and collaborating with outside agencies to provide those kinds of services, right? So she may be developing contractual relationships with hospitals, home health agencies, long-term care facilities. So the difference is that in the institutional model, there's greater collaboration, greater partnerships with the community, because she can't do everything. Now, she may be able to do some of it. It just depends on how her role is developed within that faith community. But those are the differences. Does that make sense? Okay, so characteristics of faith practice. All right, what it adds here is this first bullet. It adds a spiritual dimension to the practice of parish nursing. That's first and foremost. All your other nursing dimensions apply here, but in parish nursing, the spiritual dimension is included. Okay. Right, and parish nursing is also about education. Is a strong focus on education. right? The nurse, she tries to emphasize the strengths of the individuals, families, and communities, right? They see health, spiritual health, and healing are all considered an ongoing, continuous process. Okay. And then it goes through what the scope of standards of practice are. That's going to be dependent upon whatever faith community you're practicing in, the community's values, beliefs, faith practices. Educational preparation, we don't need to review that, but you can review that if you want. But there is an addition beyond your nursing degree that you have additional education on evidence of mature faith, continuing education to stay in the current practice. Right? We obviously abide by the nursing code of ethics, but we add the faith community part to that. Right? So it's the ADPI. So let's take ADPI into faith nursing, faith community nursing. Assessment. What are we assessing? You're the parish nurse. What are you assessing? You're assessing the needs of your faith community, correct? What's D? You're coming up with, help me out here. You're diagnosing, you're coming up with a list of needs, right? In your community. Again, P, we're planning what this community needs, right? We're implementing whatever programs we need to do. Okay, whether it's partnering with the home health to come in and take care of your long-term care patients. Okay, you're implementing your plan from your assessment of what your faith community needs. And then evaluation, obviously you're evaluating the effectiveness of your programs. All right, but obviously with faith community nursing, there's going to come ethical issues, right? I want you to read through slide 10. 11 is legal. 12 is financial. Just review those for me, because there are legal issues, ethical issues, financial issues in faith community nursing. Okay. National health objectives with regards to Healthy People 2020. So we encourage communities to cooperatively lend support to individuals and families to attain improved health status and can be passed on to future generations. That's important. Okay, go back into chapter 29 and find your Healthy People 2020 box. Okay, we need to review that for faith communities. And here are some functions. Last slide is the functions. What could be some functions of the faith community nurse? A lot of education, we said that. Health counseling, spiritual assessments, health risk assessments. A lot of health education. She could be acting as a liaison, a facilitator, performing pastoral care, services to the vulnerable population. Faith community nursing is really cool. If you haven't had a chance to take a look at it, it's really cool. And it doesn't matter which faith you're practicing in. But again, it goes back to cultural competence. Here it's faith competence. You need to be knowledgeable. I have two girlfriends that are faith community, they're parish nurses, we call them parish nurses at our local church. They are gifts from heaven. They are angels. They love being out in their faith community. They love visiting all the new families coming home with babies. They love it. They love doing health assessments. They love setting up health fairs. They love doing blood pressure screenings. They love doing COVID vaccinations. They're just made for it. It's really cool. Okay, let's jump into our last chapter because I want to get to our attestation questions and do that. Okay, so this is hospice and home health. Okay. All right, so home is a place where nurses have provided care for more than a century. There is such an increase in home health over the last 10 years. More and more services are moving from the hospital setting into the community setting. Would you agree with that? Does anybody work in home health? Any of this group work in home health?
No.
Right? So statistics show that people want to be treated if they can have their health care provided in their home, in their comfort, in a comfort zone, right? So home care, what does it include? Disease prevention, health promotion, taking care of episodic illnesses, right? And it's in their place of residence. Okay. It is optimum to try and do as much healthcare in people's residences. All right. And it's also, you have to be thinking about the family caregivers, right? Not only do you have your client, but you have the family that's caring for them when you're not there. So we need to take them into consideration, right? So when we define family in this chapter, it is defined as the individual that you're taking care of, but it also includes any caregivers or significant persons who assist in the client at home, right? So here's our definition of family caregiving, the last bullet on slide 5. Assisting clients to meet their basic needs in providing direct care such as personal hygiene, meal preparations, medication administration, and treatments. Okay, what happens when we work in the client's home? We're practicing autonomously with little structure, right? Therefore, your competence and creativity are essential. You're kind of out there. You know, it's not your pediatric unit patient with asthma. You're out there, let's say you're caring for an elderly family, an elderly couple who needs medication preparation. Well, they may be living with adult kids, or may have grandkids, or they may have all different age groups in the house, right? You're having to interact with all of those groups because you're caring for one part of that population, because that's what their environment is made up of. Right? So when working in a client's home, you need to be effective. You need to learn to trust. You need to earn the trust of the family and establish partnership with the family. Right? Community health nursing, you're out there. You are putting yourself out there with everybody, with the whole family unit. Okay, think about hospice nursing. You get the hospice nurse that's caring for your loved one who is dying. They have to work with everybody in the family, right? Deal with everybody's emotions and everybody's needs and everybody's questions. I need for you guys to review slide 8. I want you to review the difference between population-focused home care, transitional care in the home, and then home-based primary care. There is a difference. And we'll review that. We'll review that again. That will come up again. But I want you to please know what these 3 are. Okay, here's the difference between home health and hospice. Okay, hospice, palliative care of a very ill and dying client. What are we trying to do as a hospice nurse? We're trying to reduce distress from physical, emotional, and spiritual symptoms. Think about home care for a dying client, for a pediatric client. Think you have a hospice nurse for a dying child. Imagine how stressful that would be. So Again, we're just mixing up home care and hospice care. But what are some of the direct services that you might be providing as a home health nurse? Physical assessment, wound care, giving medication, cathing, providing IV therapy, right? And helping teach family members how to do certain tasks. Right? Those are direct care. What are some indirect care activities? Right? We're the kind of the case manager. So we may be consulting with other nurses and healthcare providers, organizing, participating with other teams to do video conferencing or getting together to talk about standards of practice, standards of care. We may be supervising home health aides. So here again, look at all the hats we wear in home care, which includes hospice care, providing direct care, case manager, advocate, educator, mentor, researcher. Lots. We know we need to also, we are practicing as nurses based on the scope and standards of our practice, right? You should be and need to be familiar with your nursing code of ethics. Right? And if you're in home health, you need to be very familiar with the standards of care in home health nursing practice. Each specific area in community nursing has its own scope of practice and its own standards of care. Right? So we have a code of ethics, we have a home health standard scope of practice, and then we have a hospice palliative care standard practice. I want you to read slide 14 about the Omaha system. All right. It's a system that developed a structured and comprehensive system that could be both understood by and used by members of various disciplines. It was the coordination of tracking for community health so that everybody could participate or everybody was involved. It was coordinated. It was case managed. Right. And when you work in home health and hospice, you may need additional education. You may need additional certification. And there's certainly a lot of interprofessional collaboration. Okay. So slide 16 through, I want you to take a look. We'll come back to this, not today, but we will come back to this. I want you to look at slide 16 through 21, okay? Because it talks about, we think about quality care in the hospitals. There's also a whole nother section of quality management in the home care setting. Evidence-based practice, best practices, and just like we talked about in our last chapter, there's ethical issues, there's legal issues, there's financial issues when we talk about home health and hospice care. Okay, and that's what that talks about. The 16 is about quality, 16 and 17, and then we talk about legal, ethical, and financial aspects of home care. So I want you to read through those. Okay. So there's our 5 chapters. Everybody feeling pretty good? Has this been helpful?
Yes.
Okay, let's go to our, everybody pull up their attestation. I have to go find it. Hang on. Somebody, while I'm trying to find it, somebody read the first question, read the questions, please. Well, you all did week 3, so thanks for going in and organizing or researching that and getting to it. Okay, what are the two parish-based models for faith community nurses? Remember? Congregational and institutional, right? Oh, shoot, we should, that's in the book, the 5 practice models. 5 practice models for home health and hospice. I think they were in. Is that it? What's the question? What's question 2?
Please list the
5
5
practice
practice
model-
models for the home health and hospice community nurse.
Here you are. Well, practice models. Oh, wait. Somebody go into the book. I think they're in there. Hang on. Character, is this it? Let's go to the book. So say, read that question one more time. Somebody?
Please list the 5 practice models for the home health and hospice community nurse.
Practice models. Okay, that answer is in the book. 5 practice models. Let's see. Okay, where's our practice models? Did anybody find it that reviewed the practice models? I'm just trying to help you guys out in finding the answer to this. Mm.
It says in parentheses that it's the interactive lecture. So would it be
Yeah,
on
we
that?
don't. Yeah, we don't have the interactive lecture anymore. Oh, right here. It's right here. That's why I highlighted. 5 models of practice are described in this chapter. It's that population. It's that slide on population, transition. Yeah. So remember that slide I asked you to review? So it's transitional care, or excuse me, population focused home care, transitional care in the home, home-based primary care, and then our home health and our hospice and palliative care. So that is on page 537. Okay. All right. How did we do for time? 10:58. Okay. We got 2 minutes to spare. Questions, feedback, comments? Has this been helpful? We learned a lot today. We learned about rural health, migrant health. We learned about parish nursing. We learned about home health and hospice. And then we learned about our vulnerable populations, our homelessness, mentally ill, teen pregnancy, alcohol. Shaylee, no, I have to go right into one of the at-risk meetings. So let's just finish out the class. I'm done. If anybody wants to stay on for any questions, I will, but I want to be respectful of your time. Okay. So I'm hoping by the end of the day to share with you guys the study guide for exam 2, because 2 of the 3 weeks we've now covered, because exam 2, which is in week 6, in 2 weeks, is weeks 3, 4, and 5. Okay, so today we covered weeks 3 and 4, and next week we'll cover 5. Right? So 2/3 of the study guide you should already know, or we should have reviewed today. Make sense? So hopefully have that to you by the end of the day. So
Professor Marvel, I emailed you. I have to get off for sim, but
Yeah.
I can email you about the hospice case study.
Oh, yeah. Okay. Yeah.
Thank you.
Did you, if anybody's having problems with the case studies, you need to start with Evolve. So can you reach in your student resources? There's a place to reach out for Evolve resources, which is where your case study is.
Okay, I will do that after sim.
Has
Thank you.
let me ask a question for the rest of the group. Has anybody accessed the hospice case study yet?
I did. I finished mine.
Okay, so it is available to download. Okay, so we have to figure out, Kylie, why you can't. So let's start with Evolve. So for everybody that's having an issue, I need you to go to your student resources, go to Evolve, reach out to them and start there, because it is available in your shell. You need to be going from your shell. You need to be using your Fortis email. There's a whole bunch of rules. Okay. All right. I'm going to stop
Thank
the
you.
recording.